Hello, everyone. The title of our study is Regional and Racial Ethnic Disparities in State-Level Use for lisdexamfetamine amidst the COVID-19 pandemic. My name is Yeager.
My name is Anne Marie.
My name is Joanna.
My name is Vanessa.
My name is Angelique.
My name is Janet. And jumping straight into it, the primary goal of our paper was to investigate the current trends in an ADHD medication called lisdexamfetamine, otherwise known as LDX, prescriptions across the United States. We also wanted to see whether the COVID-19 pandemic may have factored into these trends.
We collected national and statewide data for lisdexamfetamine prescriptions using Medicaid, the automation of reports and consolidated order system, also known as ARCOS, and the American Community Survey. We completed correlations between lisdexamfetamine prescriptions and race, ethnicity, demographics per state.
In terms of results, these two graphs show how the distribution of lisdexamfetamine was given through prescription per enrollee given by Medicaid data and the milligrams per person given by ARCOS data. So this graph further shows how Maine and Wisconsin were statistically significant in terms of being above the 95% confidence interval, and this data was given by Medicaid. And then to your left, the milligrams per person graph is showing how Louisiana and Hawaii were statistically significant because Louisiana was above the 95% confidence interval, whereas Hawaii was below the confidence interval.
Here we can see that after our statistical analysis, quarters 2 and 4 had significant changes in their lisdexamfetamine prescriptions from 2019 to 2020. It also shows that the South had the highest number of prescriptions and the highest amount of milligrams per person in its states. The South also had the most significant change during the COVID-19 pandemic. Hispanic Latino populations showed to have a strong negative association with lisdexamfetamine distribution, where non-Hispanic white populations showed a strong positive correlation.
For our discussion, there were regional and racial ethnic disparities that still must be addressed. Further research could look at other marginalized populations, and the data suggests that changes in prescriptions between 2019 and 2020 could be attributable to the COVID-19 pandemic.
One of the limitations of our study is that we were missing 2020 data for Medicaid, therefore we had to replace it with 2019 data. And another limitation was that we were unable to account for independent insurers. We would like to thank everyone so much for taking the time to listen to our presentation today.